we are starting, this meeting is very important for us and our partners in Georgia, because that's important discussion on how we need to transform the harm reduction services because of the new substances, stimulants use, and non-injecting drug use and chemsex practices. And there are plenty of experience already gained in the country, but that's a question how this experience could be put it in wider sharing in the practice, in harm reduction practice, in programs of global funds supported and state supported programs. And our agenda was sent to you, and actually it will be 1.5 hours. I hope that we will be in time for this. And we will start with several researchers on of changes in drug staying and drug use, and then go to the practice of response and models of response. And we will have opportunity at the end of the meeting to see what in our region, what other experience we already have in Moldova, for example, for of harm reduction for non-injecting drug users. So, and I'm giving the floor now from the very beginning to Ada Beselia, who together with Eliza Kurtsevich from Eurasian Harm Reduction Association, they done research study on the use of new psychoactive substances in Georgia recently, using the Swansea University from United Kingdom methodology of the assessment. Please, Ada, floor is yours.
Hello, everybody. I thought Eliza wanted to have some introduction for 2-3 minutes, maybe.
Yes, then Eliza.
Thanks. Thanks a lot. It's just like a short. So first of all, welcome everybody. Really happy to see so many people, and not only from Georgia, but also like from other countries. So really, really nice to have all of you here. And just shortly before Ada will give and show a presentation on the research conducted in Georgia on new psychoactive substance use, which was done actually last year. I would like just to shortly give information about the overall research, because this research was, as Anna mentioned, was conducted together in cooperation with Swansea University, law faculty actually of Swansea University. And we wanted just to analyze and to see like the situation of NPS use in Central and Eastern Europe and Central Asia region, because we heard so much from the community of people who use drugs that drug scene is changing, but we never could find any information on, or there was like lack of information or studies made on this. And we started actually with Belarus and Moldova. Like, first of all, we did our research there, and I'm really happy. And I know that Ala Yatska today also is here. She's like from Moldova. She made a research in Moldova, and she will be able to also share her own experience on the research and how later on they incorporate different interventions for non-injecting drug users in their harm reduction services. And the second stage of our research was conducted in the Kazakhstan, Kyrgyzstan, Serbia and Georgia, and the third stage was conducted in Estonia and Lithuania, and very soon, actually this week and in a few weeks, we will produce 2 more reports on NPS use in Estonia and in Lithuania as well. So I won't go so much deep into the details about each country, because each country is very unique and has their own patterns, and I know like different drug use scenes, but Ada, I would like to invite you to present now the results of the study conducted in Georgia last year. The floor is yours.
Thank you, Eliza. Can you see my screen? Oh.
Yes.
Thank you. Hello, everybody. Once again, I'm happy to have the chance to present study findings with you. Let me introduce myself. I'm Ada Beselia, researcher from Addiction Research Center, Alternative Georgia, and I conducted this research last year with the supervision of Eliza. Today, I would like to talk about just study findings because of limited time, and I hope we will have a chance to discuss local context and local situation during discussion. Study methodology was implemented in 3 stages. On the first stage, desk research was conducted to collect data from the literature, such as official reports, vast media reports, or peer-reviewed publications and documents from government or international organizations. Then questionnaire was prepared, and on the second stage, structured interviews with key respondents were conducted, and on the final stage, analyses were conducted and some recommendations were prepared. In total, 36 interviews were conducted with key respondents, and the respondents were representatives of harm reduction services, representatives of treatment medical services, one representative also from National Drug Monitoring Center, and people who inject drugs, and also people who use just NPS. For example, young partygoers, MSM community members who sometimes practice chemsex, and also sex workers. 23 respondents out of 36 were drug users. Unfortunately, law enforcement institution did not respond to our official request to participate in the research and share their information, so we don't have information from their side. Study started in January 2020 and finished in June, but data collection took place in April and May. The Ethical Review Commission from Swansea University approved study methodology. All study participants were 18 years or older, and informed consents were received from all of them. And because of COVID-19 restrictions, all the interviews were conducted online. Key topics which were explored during this study were NPS characteristics, usage patterns, obtaining methods, prices, impact, risks and consequences, how users see what are the risks, harm reduction and medical services for NPS users, overdoses and possible responses, and difficulties and problems associated with NPS use. According to participants, NPS were categorized into 3 main groups, and they were synthetic catechins, hallucinogens, and synthetic cannabinoids. And the most frequently used substances were NPS substances. I mean, were ketamine, N-baum, methadone, speed, alpha PVP, and spices. Other substances which did not fall into these 3 main groups were fentanyl, which is opioid type NPS, and also ketamine, dissociative anesthetic. And the participants used to call some slang names also to NPS. For example, in case of synthetic catechins, they called bath salts or just salts, crystals, flaca, methadone, and so on. In case of hallucinogens, for example, they called marks, blotters, gin. What is interesting is that synthetic cannabinoids usually are called bio in Georgia. It's a term to describe spices, synthetic cannabinoids in Georgia, and mostly users call bio marijuana or bio smoke to synthetic cannabinoids. Polydrug use with the practice of mixing several substances together was common, and there were some widespread combinations among users, and some of the combinations had some names users used to call them. For example, ketamine plus speed plus amphetamine was called the Trinity of Berlin, and also LSD plus mushrooms and plus bio marijuana was called Candy Flip. When asked what was the reasons for making these combinations, reasons were different. For example, some participants noted that they wanted to prolong or intensify the drug's effect. Some wanted to change one drug's effect by adding another, for example, to change stimulant effect with hallucinogens effect. Some wanted to reach drug kick-in levels sooner. Some wanted to handle it at Khadniak, a drug which is drunk hangover. In case of sex workers, They noted that NPS helps them with work performance and they feel more free and less nervous. But when I asked if they had more possibility and more money and more option to choose drug, if they would choose NPS, they noted that no, both of they were two sex workers in the interviews, and both of them mentioned that they would choose, for example, GHB, which helps them to increase their sex drive. As for ways of taking NPS, smoking, sniffing, swallowing, injecting, sticking blotters under or top on their tongue, and putting drops in the eyes were common. In case of injecting, it was interesting that just the people who had already practice of taking some drugs by injection way, for example, some opioids, they injected NPS and not other users, for example, young party goers or MSM community members. When asked what was the reasons they usually choose NPS, user respondents, named, for example, lower cost, and they mentioned that usually NPS are 2-3 times cheaper than traditional drugs. For example, if you can buy LSD for approximately for $40, you can buy N-Bomb for $10 or $15 just. And also for some of them, more potency than traditional drugs were the main reason. And for some of them, that reason was that NPS are easier to access and there are more availability on the markets. As for ways to obtain NPS, one common way was online drug markets, such as Madanga and Party Dog. When drugs are sold usually online, sellers put the orders in advance somewhere, usually outside of the city, and after payment, users get location details with some pictures where their drugs are hidden, and they can go and collect there. And users mentioned that it's the riskiest way of obtaining drugs because of the fear of the police. Also, one common way was social media apps such as Telegram, Viber, and WhatsApp. Especially on Viber, messages are randomly sent to the people, mostly in Russian language. And one, as participants noted, safest way is practice of direct hand-to-hand buying from dealers, where the mediators, middlemen, so-called legs, plays the main role. And as I mentioned, participants know that it's the safest way because it's mostly based on the friendships and informal social networks. Then asked about key risks and consequences. Mostly all participants mentioned that first risk is overdose, because usually it's a common practice in Georgia. Unfortunately, then people are buying one substance and it turns out to be another, and usually they don't know what they are taking. And from expert side, one main key risk was noted that it's impossible to identify the majority of NPS and its effect and potency. And experts, especially from medical centers, were worried about that fact. And interesting is that none of the participants, user respondents, did not, none of them mentioned any physical risks associated with NPS use. They mainly named the mental health risks such as paranoia, hallucinations, flashbacks, nightmares, panic attacks, schizophrenia, and so on. And none of them mentioned any physical risks which can be associated with NPS use. Health professionals, as well as the community of people who use drugs, lack knowledge on responding to specifically NPS overdoses. And one respondent, ambulance doctor, noted that there was just general protocol for overdose response, which was categorized by drug groups, and these drug groups don't include NPS. In medical services, NPS are categorized in any of 5 groups: psychostimulants, hallucinogens, opioids, cannabinoids, or sedatives. And there is no specific treatment place for NPS use, and medical services does not have any protocol, treatment protocol for NPS use. And during medical examinations, cases involving NPS with other drugs are often labeled as polydrug use. Narcologists noted that people apply for the treatment usually when they already have developed some mental health issues, problems connected to NPS use. And in this case, they are dealing with dual diagnosis where narcologists and psychiatrists starting treatment process together. As for harm reduction services, participants noted that harm reduction services are important, but they are not enough. Especially for people who use drugs in non-injection way in Georgia, because existing harm reduction services don't correspond to the new drug trends and related issues in Georgia. And from experts and also from user side, there were suggested some services which should be developed, implemented, such as provision of pipes, foils, or paper tubes and cards, drug checking services, also peer-based interventions and programs, and distribution of some information materials and training programs for employees of harm reduction programs. What I want also to mention is that field experts see the necessity of implementing new harm reduction approach, but they consider it's better to implement it independently of existing services, because they think that existing harm reduction services are not ready to take new challenge and to attract new users, especially young users who take drugs in non-injection way. But at the same time, harm reduction services representatives consider that new harm reduction services should be incorporated into existing services. But when I asked them if they were ready to take this new challenge, they said that they will need some training on NPS and related issues, and they will be ready for it. As for challenges of the study, one biggest challenge was that there is no available consolidated information, and available information is not integrated and is not enough to draw significant conclusions about NPS use trends and patterns in the country. Also, we were unable to conduct interviews with key respondents from law enforcement, and we had difficulty in gathering the necessary number of focus group participants online, and that's why we conducted individual interviews instead of focus groups. According to the study findings, following recommendations were prepared: that there is need for consolidated and integrated data in regards to NPS use in the country. Future studies are essential on the scope and patterns of NPS use, especially in various groups, for example, in young party goers, in MSM community who practice chemsex practice, and also in sex workers. From harm reduction and treatment service side, there should develop tailored interventions that respond to the needs of people who use NPS. Also, prevention and harm reduction strategies should be elaborated together, and clinical protocols should be developed. New harm reduction approach should be developed, and some state agencies should produce accurate and transparent data on overdose. That was all I wanted to share with you. I will be happy to respond any of your questions. Thank you for your attention.
Thank you very much, and I'm encouraging participants to write their questions in the chat and their comments. And now I'm giving floor to David Atiashvili from Alternative Georgia to present research which organization did, and I guess it will be in Georgian. So everybody who is listening us and do not are not very very good in Georgian, please switch on the English channel. There is interpretation into English. Yes, David, floor is yours.
Thank you, Bana. მოგესალმებით ყველას. მე წარმოგიდგენთ შედეგებს რამდენიმე
presentation about the results from different studies that our organization held for the last 3 years. All these studies were focused on nightlife and drug use during festivals or in nightclubs. Here we see the lists of these studies, and the first one was published, and by the way, 2 of them, Ada and Data Subeliani, made a master's paper for that, and I mean, it was their master's program, but as for the 4th one, it is not being published yet. But as for the results are combined, and I took a little bit from different researches to create a certain picture about what we know today. What we know about the use of different psychoactive substances during nightlife. We may not have that much information, but we can draw certain conclusions. The people are young, mostly, well, the average age is 24, and about 40% of these people are women. We're talking about the women who confirmed that they are using drugs in the context of nightlife, and 2/3 of these people use drugs. And it is not only in the nightclub or festivals, they also use drugs out of this space. And 2/3 actually, well, that may sound big, but we cannot generalize these results. But the groups that we have surveyed, 2/3 of participants were saying that they have used various drugs, well, when they were engaged in nightlife, but 40% said that either they always use drugs when they go to the club or the festivals, or often. And it was quite anticipated that men used it more. What picture we have about nightlife? As a rule, it is not limited to one substance only. There are like 2 or more substances used usually. The most frequently used and widespread substances, MDMA, ecstasy, and amphetamines, ketamine, also marijuana and synthetic cannabinoids, and also there were other LSD and other drugs as well. It is quite often to use unknown substances. This means that when they get a gift,
რა ნივთიერებას მოიხმარს და რა არის შემადგენლობა ამ ნივთიერების. როგორც წესი, რა ნივთიერების მოხმარებაც არ უნდა ხდებოდეს, ალკოჰოლს აუცილებლად მოიხმარენ პარალელურად და აქ გამოიკვეთა, რომ ვითართ 2 მიზეზის გამო ხდება ალკოჰოლის მოხმარება. ერთი ეს შეიძლება იყოს ალკოჰოლთან კომბინაციაში უკეთეს, ასე ვთქვათ, სასურველ შედეგს აღწევენ, ან ალკოჰოლის მოხმარება ხდება გამოსვლის ეტაპზე, ეგრეთ წოდებული ათხადნიაკის შესამსუბუქებლად. კომბინაციები, ეხლა მე არ დავიწყე ჩამოთვლა ამ კომბინაციების, მაგრამ არის რაღაცა მეტნაკლებად სტანდარტული სასურველი კომბინაციები ნივთიერებების იმისათვის, ან თანმიმდევრობა ამ ნივთიერებების მოხმარებისა იმისათვის, რომ
substances in order to achieve the desired effects. And in this population, we had very little information. Actually, they had very little information about the potential risk associated with the use of a certain substance. Obviously, we were interested in identifying what is the main driver, what is the main motivation for the youth to use the drugs in clubs or in the festivals. And one clear reason was identified. These substances are understood to be an inseparable part of having a good time in this environment, and that it helps the people to hang out with friends and to perceive music, and it becomes more pleasant. As a rule, drugs are not used only for feeling the effect of a certain drug, only for intoxication. Mostly, they use drugs in the environment of friends, when they interact socially. It's a group event. And as I already mentioned, there is a very low perception of risks. However, when there are some understanding of potential risks, there are certain strategies for harm reduction, and sometimes they try to refer to these strategies. Let's say, taste one little part of the pill to wait for the effects, and then they can consume the remaining pill. Excuse me? Or they may not consume alcohol with them if they have an expectation that they may experience something, some adverse effect if they mix the substance with alcohol. So this is something like a shared approaches. And what was interesting, by the way, when these people identify themselves, or when they identify their patterns of use, they make a clear distinction between themselves and other users, so-called problematic users or injecting drug users. They distance themselves from them. Also, there's a very low level of perception about how problematic this use can be. And the drug use is only associated to having fun and having good time only. Challenges. Challenges that were identified and that we, the researchers, are facing in regards to working with this population. These people, and by the way, that was not present in Georgia only, that is also prevalent in other countries. They do not really engage in researchers or support services. They do not want to get engaged. And why? Because they do not think that they need any kind of support. No. For these people, main source of information, drug-related information, it is friends or internet. And it is important to know that. When we plan a certain intervention with these people, if we want to work with these people, we have to have some knowledge about that. And another problematic thing, internationally, by the way, in fact, as of today, there is no recognized or well-tested or database or evidence-based intervention that would work individually with them. Whatever interventions are now applied in clubs or in festivals for reducing the drug-related harm, this is just the new regulations or staff training or some providing general information. But there is no effective, tailored, or individually focused interventions. Unfortunately, it is missing. It is non-existent. This is actually what I wanted to say, and I would like to get your questions now if you have any, and I'll be happy to answer to your questions.
Thank you, David. And we have question from Elsie from EMCDDA. How do you know about chemical content of the drugs? Is there any regular exchange of information with police laboratory in place, or any possibility of drug checking, and how clients know what they're using?
Okay, what language should I speak now? Okay, ქართულად ვიტყვი და ნუ ინგლისურად არნიან. პოლიციასთან
As for the police, in fact, we do not have any practical cooperation, and quite on the contrary, it was very difficult to obtain information, in some cases, information about the ingredients of the substance. So, because we had several cases of overdose, and it was difficult to get information about those substances that caused the overdose, and it was very difficult to get information when we had overdose cases. The people know what they use, and that is based on the experience of friends. Also, they observe the effects, visual effects. Also, they listen to what the dealer or the friends will tell them. As for drug checking, is Temo here, by the way? I don't know. There is an attempt, and there's an organization, Mandala. There's an attempt to introduce this intervention. They try to do that, but there are barriers, legislative barriers among them. And I know that at this stage, they are now working on it to expand that and to make sure that more people have the possibility to check the drugs and to actually know and to get more information about what ingredients they have. But so right now we don't have any. Yes, that's so. I will have a presentation, and then I will speak about that in my presentation.
Thank you. Thank you. I guess that we will go further because we are very short in time, and then we will have, I hope that we will have some discussion and possibility of comments. And now I want to give a floor to David Subiliani, because he also had some assessment, have done this assessment. And David, could you please be short in 5-7 minutes maximum?
Yeah, thank you very much. Well, drug scene changes so fast in this country, and especially in COVID times, it has changed really drastically. That I don't really think that like a research that I did like a couple of years ago is really relevant anymore at the moment. But really the needs that came up that time, I guess, are similar to what we have right now for NPS users. Just I wanted to start with the last question that came from EMCDDA. The one source why we know about the substances is that Georgian government basically made the shift, and they transferred number of NPS substances like alpha PPP, MDPV, methadone, as well as NBOME from NPS to normal drug. And that happened because in the justification paper they have indicated that they had seized quite a number of those drugs. So we know that these substances were in circulation in Georgia, also from official sources. Well, when it comes to needs, the biggest need that the people who use non-psychoactive substances is the information. Most of the users, they don't really have accurate information about the actual substances, about the risks associated with them, etc., etc. Then the basic need, the biggest need, like perceived need of users is what Ada also mentioned, is the commodities. Well, I am not only a researcher of pastimes, but also a ex-user of NPS substances. And I know when we were, using all these, synthetic catechins, all of, all peers and, all the people who are using, we were just chasing normal foils, the foils that were usable for us when we wanted to chase those substances on foil. We were trying to vapor them, and that was a main issue. In normal shops where we could get the foil was either very thin, not really useful, or very thick, etc. So we would just try to get the normal ones from the restaurant. It was hard to achieve, and harm reduction centers wouldn't have those things. We wouldn't get also the pipes, the special pipes to use the crystals, to burn crystals through pipes. That wouldn't be that would be a problem also in Georgia to get those, and people would have workaround to use this kind of substance. Syringes, because many NPS users switched to injecting practices, and those were not particularly linked to harm reduction services, because the current harm reduction services traditionally used to work only with the opioid users. So there was a big gap, and these people, NPS users who are using those substances via injecting, they would rely on pharmacies to get the needles and syringes. So that was an issue, because stimulant NPS users, they usually use a lot of those, and in a normal setting where you come up with a couple of syringes from that pharmacy, you end up in 1 hour, 2 hours, having used all the syringes, and then no one is there to go out and bring the new ones. So then when it gets messy and people start changing syringes and stuff, so there is a gap. Even though in Georgia we have syringe program, needle syringe program, those do not usually reach the NPS users. So there's a gap. The mental health issues would come up as a common issue among the stimulant NPS users, especially. Many users would have the perceived need to see a counselor or whatever, but not many counselors were trained to serve this particular type of clientele. They would go through a normal treatment with psychologists or psychiatrists, but those wouldn't really be kind of trained to respond to kind of substance use part of the thing, so that was an issue, and only few counselors would be trained to give those kind of adequate services. So there was a need for that also. This is it basically, just because current context is really different because of COVID. Nightlife has kind of disappeared, not almost entirely. All the practices also disappeared. The market also kind of changed a lot. If you go to online, instruments where we would buy NPSs, they are usually empty. You don't really find the offers there anymore. We believe that not much NPS is being used at the moment in country, and people have gone back to traditional substances mostly, but that doesn't mean that it won't come back. So when the COVID kind of situation disappears and nightlife kind of gradually comes back, we might see the markets reopening for this kind of people, and the same needs coming up again. So we have to be kind of careful. Do you think that today is kind of a bit kind of calm situation? We don't say that, we don't have the situation we used to have like 6 months ago, 1 year ago. It was really kind of bad, but that is coming. That will come back, and as we know, it might do so very, very quickly, as it happened in the past. This is it, kind of a general review, and I'd be happy to respond to questions if there are any.
Thank you, David. Thank you very much for your overview and from community point of view and from the expert point of view. And actually, we're switching to the from research part, from assessment part to the response part. And I'm giving floor to Georgi Saselia from MDM Georgia to review new harm reduction service models for non-injecting drug users and people using stimulants, NPS, and practicing chemsex. Georgi?
Yes, hello everyone again. Thank you, Anna. It's a pleasure to be here and good to see the diverse participation from the participants from all over the region. So today I will briefly present you the service delivery models that we, the doctors of the world, plan to implement as the pilot project in Georgia. Currently, we are at the stage of elaboration of this model. So within my presentation, I would rather cover more general concepts and ideas, which are the matter of the further, let's say, polishing and work in collaboration with the stakeholders and community. So it would be absolutely appreciated to receive the feedback from the participants today. How we frame the general concept of these models, we call it new harm reduction service models. It can be argued whether it's new or not. However, for our countries, as my colleagues in previous presentations already mentioned, these services are considered as a novel as long as they are not currently introduced, presented, and implemented. So I will briefly touch the issue related to the preconditions, meaning to the context which led us to the decision to think about and start thinking about the implementation of the models. I won't go deeper into the details because this basically repeats everything what was just mentioned by our colleagues, but just generally go through a few points. Is that we observe that there is use of the stimulant and psychoactive substances. We see that there is increase of the non-injectable drug use, including the amount of people in recreational settings for recreational purposes. We lack the reliable data and evidence regarding the overdose and overdose tests. However, there are some sources of information, including media reports, civil society organizations working with field and community testimonies, reporting number of cases throughout the years of the overdoses and related deaths in the electronic dance music scene. And this is quite a challenge at the moment, mainly caused by the use of the new psychoactive substances or the drugs which are not the benefit community is not aware of what they're using, etc. We observe in parallel the use of the drugs in sexual context among MSM and LGBT communities, including the emerging practices of chemsex. Now, when we say the sexual context, what does it mean and why do we separate it from chemsex? Because there is two types of the practices which are a bit different from one another. And in sexual context, I mean when people prior to the sexual intercourse and during it use the drugs for the stimulation of sexual practice, but not necessarily it is can be considered as the chemsex because it engages the drug substances which are available at the moment and not necessarily the combination of the substances which are generally used for the chemsex purposes. As was mentioned, the average age is 24 years, as Dr. mentioned in his presentation. So we basically observe the change of the characteristics of the drug users, which are the young population, which more use in recreational settings, and who have limited awareness, knowledge, and experience of drug use, which increases sufficiently their risks to the complications and overdose. So in response to this context and situation, we see that harm reduction response which we have in the country does not quite answer to these challenges. The programs that are currently implemented within the support of the Global Fund program and partially the government fund since last year, they're directed primarily to the injecting drug use practices and the purpose of prevention of HIV. While all the challenges that remain, which I mentioned in terms of the young users, operational users, campus purposes, they remain unanswered, and these people are not anyhow linked to the harm reduction services, prevention services, or addiction care and treatment services, and there is a very low perception about their own risks, and they do not necessarily connect themselves to be in need of the unity for the care. There is always a question regarding how the, let's say, non-injecting or recreational drug can be framed within the concept of the national HIV response, if it is anyhow linked to it, and what are these links. So basically, we can say that there are sufficient links, not only directly related to the drug use practices, which also are in place, however, also with the high-risk sexual practice under the influence of the drugs, which increases the risk of okay. Sorry for the and another thing is the intersectionality among the target communities, which is also, we have the lack of the consideration of the cross-cutting issues and intersectionality among within the national harm reduction. So basically, considering this context and situation, the concept of our models is to introduce the services for injecting drug users, including those with stimulants and psychoactive substances, including those in recreational settings, introduce services for LGBT communities practicing drug use in sexual context, chemsex, and promote intersectionality among the different communities. Specifically, these are the target groups. I won't go through them. At the moment, it's just the same with our already mentioned. So, what is the package of the services that we intend to pilot? So basically, the idea and the concept is that there is a basic and traditional package of services which is currently available, and you can see it on the left side of the slide, which is HIV and hepatitis C testing, STIs, needle and syringe program, naloxone distribution, risk reduction counseling, etc., etc. And then what we intend specifically to pilot is the what we call add-on services, including non-injecting harm reduction paraphernalia, so-called rave recovery interventions, drug checking, and the chemsex package specifically for MSM and LGBT communities. What is important here is that we do not intend to pilot this model as the separate services. However, we consider it as an integrated part of the available available and implemented services currently in the country. The idea is that these services should be available in a comprehensive one-stop shop principle, however diversified in terms of the target group, not only for injecting drug users, however, for example, HIV and hepatitis C testing and rest of the services should be also available for the rest of the target communities which we mentioned. What we mean under add-on services, and again, this is just a concept and it might be polished later on and somehow adjusted or further reevaluated, but the general idea is to, like when we talk about the non-injecting harm reduction, we talk about the smoking pipes, glass tanks, mouthpieces, foils, Nordic straws, etc. When we talk about rave recovery, this basically includes the distribution of the materials which intend to somehow prevent the health complications in the electronic dance music scene, but through provision of such recovery materials like magnesium, 5-HTP, vitamin C, earplugs, drinking water, etc., including the services linked to the bed trip management, first aid, and provision of the chill out areas. I think Temo Hadeshvili, representing Mandala, who are partially doing these services already for a few years, will maybe talk about their practice a bit deeper and comprehensively. So for chemsex, we think that the package should include the harm reduction distribution materials, including the injecting and non-injecting paraphernalia, some specific materials, for example, the booty bumping for the people who use the drug, consume drugs from the rectal areas, etc., and the standard, let's say, HIV prevention services, including self-tests, condoms, lubricants, etc. And regarding drug checking, what we are reviewing at the moment is the possibility to introduce I mean, it's partially already again available with Mandala. The two types of the checking methods is the reagent-based testing as well as the more comprehensive chromatography-based testing, both on site, meaning in the drop-in center of the community organization, as well as in the outreach, in the electronic the musical festivals and nightclubs. So integrated service delivery model basically looks like it. It means that we look that there is the standard package available with the Global Fund. We intend to add on the services which I already described, and to perform it as the comprehensive model of services available for community in every setting where they need it, basically. So service delivery outlets, as I mentioned, is considered to be the drop-in or community centers, outreach, and there is interesting consideration about the vending machines, which has been piloted by the project implemented by Alternative Georgia, and it might be also point for the discussion and consideration how we can integrate some materials into these vending machines, which is very interesting and good practice which recently was introduced. So expected benefits which we have is to basically reduce the drug use related harms among the target groups which I mentioned. Most importantly, it will give us possibility to recruit and link to care, including harm reduction and the secondary care, the people who are not anyhow covered within the current services, not only harm reduction, but also, let's say, addiction care and treatment services. It will contribute significantly to prevention of HIV and other STIs through covering the populations which have sufficient risk in terms of sexual practices, but are not currently or are, let's say, limited in coverage with the existing services. And it will improve also the access to complex and diverse services through, let's say, mainstreaming and promoting integrated intersectional approach. So briefly about the process, we are intending to implement these models in partnership with the two organizations. It is Mandala, which is a community organization of people with drugs, providing services for including non-injectable drug use, etc. It is Equality Movement, which is LGBT community organization. So currently we're working at these models. We plan to finish the work somewhere around May, June, and maybe to start the pilot since September, maybe October 2021, to pilot it as the first stage, then to see how effective are these models and how we can scale up and integrate them into the national response. It will be, I don't know, HIV national strategy, national, what is called the anti-drug strategy, etc. So basically that was it. Thank you, and I would be happy to respond to the questions.
Very impressive plan, and actually very impressive list of services you want to introduce. And I hope that Georgia again will be the example for all the region, because all the region want to have the specific dedicated services for non-injecting drug users. Actually, now I'm happy to give a floor to Temo and to Maya Uchenishvili from Kuratio International Foundation on policy recommendation for introduction and scale up of drug checking services in Georgia, because that's as we all know, the legal environment is the key barrier for introducing drug checking services. Who will speak, Maya or Temo? How you will?
Okay, thank you, Anna. I will start and then we'll give floor to Temo. Temo, if you will help me with sharing the first slide. So first of all, thank you very much for organizing and arranging this very interesting meeting on the very important issues emerging in the drug scene of our country. So probably most of you know me. My name is Maya Uchenishvili, representing Curatio International Foundation, and one of the authors of this policy brief, which we are going to disseminate today. So I would like to touch the point about this policy brief, how it was evolved. It was the part of a program which we are conducting. So our organization is a European regional hub of program which is globally run and supported by the Alliance for Health Policy and Systems Research. And the aim of this program is to support evidence-based policymaking and evidence-based advocacy efforts in Georgia and in the region as well. So as I mentioned, we were running this program, and Temo representing Mandala. So he is one of the fellow participants of the program, and we together with Temo and Georgis Oselia from MDM discussed the highest priority issues for our country, and decided that the drug checking, and as we heard, is one of the kind of a most emerging issue. And yes, we decided that this is important topic, but how it should be introduced, what program framework, what legal framework, what kind of service provision should be considered was under question. So that's why we developed this policy brief, and Tema will go through the outcomes of the document itself, and I will stop here. But before stopping, I wanted just to mention that the program I mentioned, which supports evidence-based advocacy and policy-making issues in the region, so will be open for regional participants in this summer as well. So any of you, if you will be interested to be part of this program, we will be happy to host you this summer if COVID-19 restrictions will allow us. So thank you. This was very briefly that I wanted to mention. Now, Tema, floor is yours, so you can start. Thank you.
ძალიან დიდი მადლობა. ისმის ჩემი ხმა და თუ ჩანს პრეზენტაცია კარგად.
Thank you very much. I hope you can hear me and you can see my presentation as well. I will start. First of all, thank you very much for giving me this opportunity to make this presentation. But before I do that, I would like to thank Curatio for all their support, because we elaborated this issue under the internship. And they really helped us to work on this topic, and especially Madonna. Now, topic for today, drug checking services. And I will use the word drug checking services in Georgian as well, drug checking service, so to make life easier for the interpreter as well. All right. What is the drug checking services? This is the intervention that enables drug users to understand what substances they are using based on the chemical analysis. And then we will know what is the substance actually, and what the ingredients are, and also to determine how harmful or dangerous it can be for our health, and also to understand if there are any contaminants or some additive substances to that, and why this is relevant for Georgia. This is because the drug scene has changed in Georgia significantly, and we know that Georgia and in other countries, the drug scene has changed a lot. The drugs have changed, and also the patterns of use and the age of users changed, and also the methods for buying or selling and branding, everything changed actually, and all the needs that existed for the drug users. Now everything has been changed, and it is much more different than it used to be before. And every day, I can say that these needs should be revised. These approaches should be revised and changed and updated. It is also very important that, well, the cases of overdose and death increased recently, and there is no study or any kind of method for actually registering these cases. No agency is doing that, but we know that in the news releases, in the media, we hear that also based on our daily activities. Even with the naked eye, we can see that the overdose cases has increased, especially at the events where the drug use is prevalent. Also, existing harm reduction services and existing interventions, I mean, traditional intervention services do not meet the current needs because now we have the new drug scene and there are new needs emerged. There is no routine system for monitoring the drug scene. And the frontline work that the community organizations are doing, well, this is not understood to be a part of a big deal. And drug checking services are really relevant in this respect. Let me now say a few words about the Mandala, what we do. Mandala, well, actually, was mentioned to be implementing some activities. And let me say a few words. Right now, we're the only community organization that tries to introduce the new type of harm reduction services, which means electronic and music festivals, to have the harm reduction tents at the festivals. Also, various commodities will be also available, and there will be the group of volunteers trained. And in the territory where the electronic music festivals are taking place, there will be some activities to prevent some cases or to respond to overdose cases, and also to have the peer consultation as well. We actually we cooperate with drop-in center, and we can only say that the drug testers are disseminated through drop-in centers, but we cannot do the test ourselves at our office because of the legislative or legal problems. But recently we have introduced a delivery service, delivery of drug testers or different commodities, and people may ask the courier. Actually, they can make an order online and the courier will deliver them. In regards to our communication with the community, we do that through the social media and the website, and we have a website where we regularly upload the news or some notifications or make announcements about the activities that we are planning. As for the goal of drug checking, first, to keep the drug users informed. Okay, and to support them to make an informed choice and to decide to use or not to use the drug and to use and how. Also consult about safe consumption. This is also very important. That's a very good benefit for all the service because when the people come and make the tests, I mean, check the drugs, then also you can provide all types of information about drugs and also prevention of overdose and health caused by overdose. And obviously, this is one of the most important benefits of this service. And I think that the most important one is the connection of young and recreational users to harm reduction and the healthcare programs in general. We know that the youth and the perception by the youth that it's the health problem or they may need the services, they don't really have this kind of perception as compared to the older population, and linking them to the different services for the prevention, that is very important. According to the studies, drug checking services really supports the people to make the following decisions, and I will make a list of the services, list of the decisions actually. When they refuse to use a drug, a certain substance, so one of the decisions will be not taking that substance or drug at all, because the drug checking results will show them that there is an absolutely different type of substance, or taking less doses of the drug. Also, there are some cases when take it over a longer period of time, they take it little substance. We had 360 respondents when we did the survey, and the majority of the surveyed individuals reported that also they may decide to take it in a different environment or take more care in mixing with other substances or use a different route of administration. And from my side, as a user, these results really very tangible, very important. And my personal observation is that it may significantly reduce the risks and harm as well. The purpose of drug checking and what is the impact? Drug checking services play a significant role in monitoring and surveillance of illegal drug markets. Also, serves as a real-time consumer-centered surveillance tool and facilitating regularly intervention in the illegal drug market and also to plan the real-time response. That is very important because the drug checking services will give us the answer that there is a dangerous substance, harmful substance distributed at the particular event, or we can have a notification campaign, a warning campaign that would significantly reduce the number of overdoses or that would significantly reduce the adverse effects. Also, educational warning campaigns and informs the public health and harm reduction policy and practice, and also it enables the national response measures to intervene at an earlier stage. The MCDDA European Drug Report 2019. This is the report that I should refer to, and one of the components here was the drug checking service, together with other four components, wherefrom it is possible to get comprehensive information about to conduct a monitoring of drug scene. In fact, there are four different types of testing. I will not list all of them. We are using the reagent testers, and it is possible to use it in the field. It is possible to get the result and the information about substance, but at the same time, the superficial results can be really very important. However, there are also mobile and smaller labs where it is possible to do more comprehensive tests and checks, but I will not discuss all of them. By the way, what I wanted to say, the very first drug checking service, it was done in 1992. That was in the Netherlands. And as of now, it is available in 20 countries and there are 31 service providers. There are three types of services. That is stationary, from office, from community centers or laboratories. Also, this can be on-site or field tests. It can be festivals or nightclubs or electronic music festivals, and also postal services where delivery of self-test kits is possible, and also they can receive samples by post, by mail. As for funding sources, in 21 countries where these services are financed, from 31, 21 drug checking centers are financed by the government out of 31. And also there are central budget, state budget, and local municipal budget. Also, there are international funding agencies, non-governmental NGOs, and even the nightclubs and festivals also provide funding. Also, private and philanthropic foundations, and also there are private donations as well. And we also refer to that tool. Now, let me say a few words about the legal framework and drug checking services. It is important to create a legal framework that on the one hand protects the interests of the club and festival where these services should be incorporated and implemented, I mean, where the drug checking services should be provided. At the same time, it allows this for the safety of the implementer, whether it's a community organization or medical or anything. Because this way the interests and safety will be addressed. And drug users, when they come to the services, also there will be safety ensured for them. To make sure that there is maximum coverage with the services to ensure the best results. Now, recommendations. Well, the substantive recommendations are to integrate drug checking services into national HIV/AIDS strategic plan. Second, to elaborate a protocol of drug checking services for festivals and nightclubs, by the way, at community and civil society levels. Also, to integrate the drug checking services into national harm reduction guidelines in the Global Fund Note 4. How to include everything in this document by the Global Fund. For the legal framework, here we need to develop a legal framework for drug checking services, exemption of administrative and criminal liability for organizers, service providers, and program users. So they will be exempted from this responsibility. As for the monitoring, then ensure consideration of drug checking services as an integral part of national monitoring mechanisms of the drug market. For this, we have to build strong communication and partnership among drug checking service providers and the National Drug Monitoring Center, and also to integrate the drug checking services as the part of this system. And that was all. Hopefully, I did not speak too much, and I would like to thank you very much for your attention. If I missed something or if something was not comprehensive, then we can have a question and answer session to address all your inquiries. Thank you very much.
Thank you, Temo. And there is one question: how do you collect data from drug checking service when you are sending by post or giving a test in the festival? How you get information what is inside the drugs people using? How collect data? How you get data back?
So the question was about how we collect information. Let me say, there's a tent and the beneficiary may come to the tent, and when they do the check, we ask them to fill out the questionnaire, and there's a social worker involved. We planned that gradually, and we were not able to do that when we implemented our activities in the past, but we are trying to start that initiative now, and there will be a questionnaire, anonymous, without any personal data, of course. And then the beneficiary will say what substance he or she thinks is included in the drug, and then we are going to ask the questions about if they are going to use drugs. But before, we only had the questions about what they thought was included in the drug, and this is what we collected during about 20 festivals. So they were direct questioning.
Okay, thank you. There are plenty of questions on how does it match what they think and what they really receive as a result.
He has not turned on the interpretation function, so someone needs to explain how to hear the Georgian translation.
რასაც ტესტავთ, გონიათ რომ არის ნივთიერებები, რამდენად ემთხვევა და სინამდვილეში რამდენად არის ხოლმე დაახლოებით რო უთხრა განაწილება პროცენტული.
She translated that, and we have different results, 50-50. Sometimes it can be 30 to 70, but roughly speaking, with the naked eye, usually it is 50-50.
Thank you. We now have opportunity to learn how, because there were a lot of questions on integration of the services, new introduced services for NPS users, stimulants users to the Global Fund programs. And that's why we invited Ala Yatsko from Moldova, who managed to make one step forward in this introduction of the new services in the standards and Global Fund program. Ala, I'm giving floor to you. If you could keep you short, it will be very good.
Thank you, Anna. Hello, dear friends, dear colleagues. I'm happy to be with you today. And I will speak very shortly about our short experience on NPS in Moldova. I have some 2 or 3 slides and I will use them. So just a second. Even in Moldova, harm reduction services and programs are implemented starting with 2000. Only in 2017 we start to think about NPS because we had more and more evidence at the level of the services. People came to us and we saw that they use other substances and through other ways, not just injectable, because in Moldova, the main target group of harm reduction services were injectable drug users. So it starts from this evidence, from the client's demands, because they came to us and they faced other different problems that usually we documented in the frame of harm reduction services. In this way, we start to think how to make how to have more services and how to give the response to these people, how to try to approach their problems. And it starts with the topic for the agenda of technical working group of CCM. We start to speak at this level about this need, about this group of people, and about the difficult situation to approach their needs because we have no services, and because the services we have and are important for them, very often it's not possible to provide them these services because they are not under the criteria of our projects. So because in Moldova the budget of harm reduction projects are based on the number of clients by the clients. So if the person is not an injectable user, we will not count him or her, and this way we will not have the money for the services And it takes about 2 or 3 years. And just in 2020, when we start to to update our protocol, because in Moldova we have a national standard for HIV prevention programs within key population, and every 2 years, this standards approved by the Ministry of Health, and each 2 years this standard is updated. And in 2011, when the process started, we start to think about the integration of this this group into the target group of the standards. into the target group of HIV prevention services. In this way, NPS users became a target group. This means that they can become clients of harm reduction services. In this way, we have money and we have the opportunity to revise and to complement our service package for them that that happened in 2020 at the level of the standards, because the standards describe the package, and into this package were included additional services like psychosocial support for this group, like medical specialized care, psychiatrical care, and primary care, important for this this group of users, and they are named in this standard. So, like now we have injectable drug users, injectable and non-injectable, sex workers, and men having sex with men, like target group of national standards. Starting with this achievement, with the improvement of the national standard, we start to think in 2020, but more intensive this year, 2021, how to transform the harm reduction services in order to approach the needs of NPS users. And in 2020, Moldova applied to Global Fund for a new grant. This grant includes some important activities like trainings on working with NPS users, development of new services, and the procurement of new equipment, or this paraphernalia about we speak. In the same time, we understood that we need such kind of instructions, guidelines in working with this group, and the provision of the standards are not enough in order to organize our work. And we start to elaborate together with the UNAIDS national guidelines on working with the NPS user and stimulant user. And we used so this the guide of this guide you saw on the screen of UNODC. But I forgot to say that like okay.
The same research using Swansea University methodology was done in Moldova as well, with recommendations.
It was used a lot in our advocacy efforts, because from 2017 we have just a few evidence before or without our experience, not just our experience and our practices, like IBBS study data. But when this study, this research was made, it helped us to advocate for the importance of elaborate an additional package of services for NSP users. So in 2021, we started these interventions at the level of harm reduction services, as we have in the target group, the non-injectable users, and we pilot in first 3 months of the year some interventions with the support of UNODC, and additional to our classic harm reduction package, we bought some paraphernalia like this stem or pipes. I don't know how will be how will be correct in English, but it is used by for smoking. Synthetic catenones like methadone here in Moldova, and it increased the level of accessibility of harm reduction services to this group, because they start to come to us and to ask for services, and we have the opportunity to make HIV test, hepatitis, to speak about overdoses, to implement all other services that remain very important for this group also. So through our national standards and protocol, through that guidelines that are in process of elaboration, these are our main approaches in work with the NPS users. So the package of classic intervention still remain very important, and we will implement them starting from syringe exchange and condoms distribution and HIV testing and so on. But this package will be complemented with additional services like like specialized counseling and specific equipment for this group. Motivational, we need motivational packages, because this group are more difficult to reach, and based on our experience in this 3 months of piloting UNODC project, we saw that the motivation works in case on, and we can so it will be difficult for me to say in English, but such kind of motivational packages can improve the increase the use of the services. Psychosocial intervention are very, very important for this group, and we should and we already, but we should think more about the quality and accessibility of this kind of intervention, because they are not continuous, they are not consistent, and they are not qualitative. Way of service provision very important. The classic way of outreach and field work still remain very important, but we should move also on online space, on online channels, because we reached through online last 3 months more than 150%. So for us, it's a good number. So it was not a very hard work, but with of new users. Specific communication. Here we must work very hard, because we should improve our communication tools with the specific messages for NSP users. So we should adapt our harm reduction strategy to this group, and to speak and to adapt the messages, moving from injectable, non-injectable use, thinking about the people smoking, inhalating, and so the harm reduction principle should be applied for all this way of using that. Emoji language, very, very important, because on this internet online channels, people use this emoji language, and we start to learn it because it is impossible to understand what people want, or if you don't know some basic basic knowledge on it. Medical care, very important. Overdoses, intoxication, a lot of them in the middle of this group, because the NSP are cheap. They combine NSP with other psychosocial psychoactive substances and alcohol and methadone as well, and it is a high risk of overdoses and other problems like skin burns and other kind of problems. So now we are in the process of within a reforma of harm reduction services in Moldova, and we have the support of Department of Coordination of National AIDS Program. They have not money, but they will analyze the possibility of Global Fund grant to adapt the existing service packages. Also, that money that come from a national insurance company will take into consideration these needs, and will the medical package will include also services services for NSP users. So the most important, what happened, this is what happened in Moldova at this moment, and on the in the frame of importance of work with new psychoactive substances.
Thank you, Alla. And actually, there is the key question to share documents, how you suggest changing in the reporting for the Global Fund, like coverage indicators, and to share GF proposal, which included this part, how you formulated it and justified for the Global Fund proposal. That's actually the key question from everybody to learn from Moldova.
According to the standard, the client of the project is so the drug users who received three services, at least 3 services. For injectable drug users, there are exchange of syringes, condoms, distribution of condoms, and the HIV testing. And for non-injectable users is the same services without syringe. It's not so obligatory like mandatory, but an additional information material, it's the third service. So based on this, they count the number of clients.
Okay, I'm sorry for I'm sorry that we are a bit late in comparison with agenda, but we have a lot of discussion in the chat and a lot of information to share. And actually, I'm ready to give a floor to Marka Gogia, who wanted to say from the service provider's side, I guess, to share her perspective. Please, Marka. You're muted, Marka.
Hello to all, and it's very nice to meet you and provide some suggestions based on the points discussed today. Thanks for David Otiashvili. He mentioned that there is no specific evidence-based interventions targeted for NSP users, and the other presenters submitting interesting views to all. First of all, I wanted to mention as a program director of Explicit Needle and Syringe program that our program aims to reach people who inject drugs and their sex partners, and it's never included special interventions for non-injectors. But we, any case, provide them needed testing on HIV, hepatitis C, B, and syphilis. We never refuse them, and besides, we provide them medical consultations, lawyers consultations, psychologists. And in terms of friendly environment, there was some comment mentioned on it. Of course, they are well received, welcomed, but as we don't have attracting for them services, we don't know what the percentage is of the NSP users among the total coverage of the program, that is annually maybe 35,000. And I wanted to mention that our database does not give possibilities to count them. As regarding to paraphernalia that was mentioned for new harm reduction approach, it's very challenging point to procure them here. But if we want to dream only, it's possible. But when we go to direct activities, it's very difficult to procure and then bring them to local Georgian reality and during existing drug policy environment. But we should try. I agree with you, but we should try to change this regulation regarding registering these items here. And regarding new grant writing to the Global Fund, you all know that we currently are developing some new concept note for the Global Fund, and we are meeting with all stakeholders. Most of them are you here presenting the meeting. But just to notify you that we are not sure that Global Fund will fund these activities for NSP users, and the Global Fund is restricting its funding for Georgia. You know this situation as well, and other donors. We don't see other donors who will be interested to fund these activities in future, and also we don't need the very short period, short-term activities for these activities, and we want government to take these activities, to take care on this. I can't see at this platform anyone from law enforcement agency. Maybe you invited them, but they are not presented here. This is very challenging issue, and no one mentioned that if they will not collaborate with us, there will be no future for addiction, drug checking activities, and so on. Thank you.
Thank you, Maka, for your comment. And yes, we invited all possible law enforcement agencies and colleagues, but they I guess didn't show up.
Sorry, can I shortly reflect?
Yes, please. Now discussion is open, and you could raise the hand.
Yeah.
Yes, please.
So thank you, Maka, for the comments and for the questions. Mainly, I mean, I just would like to provide information that within the framework of the elaboration of the proposal for the Global Fund, we had numerous discussions with the principal recipient. The representatives are also present here today in the meeting, and they might also have their point. The thing is that it's not quite correct to say that Global Fund is not willing to concentrate and invest into the programs related to the non-injection drug use. However, discussion that we have at the moment is that probably it would be a good idea to look how we can generate the evidence to come with the standardization of the services, etc., and then to see how it can be integrated as the part of the program. So it is an ongoing discussion, and our idea and plan is that our pilot, which MDM is intending to implement, will contribute to this, and we can think about as the first stage within the Global Fund program, how we can concentrate on generation of the evidence and data and standardization of the services. So basically,
George, this is evidence that I spoke about. This is based on the discussion with the existing PR of Global Fund here. They had such communication with Global Fund in previous year, and they always refused to allocate additional funding for new interventions. So this is the expectation I have for the new one, but maybe I will be mistaken.
In past, Maka, in past, but now
yes.
About the new proposal there is.
Can I, colleagues?
Please, Alexandra, step in.
Yeah, so in the role of existing PR here. Cheers to all, greetings. So basically, I'm copying what George says. Yeah, there were some communications in the past, but currently the communication is that for the first stage there should be an evidence, and nobody is saying no to this approach. But it's not just a matter of putting some activities or rough points there in the funding request. Everything should be based on existing evidence and country-specific context. I mean, and this is promising. So we're looking forward for MDM's pilot. And thank you for the great work presented from Alternative Georgia and colleagues here. So everything this will contribute to the evidence generation. And I'm pretty much sure that there will be a room for supporting those interventions. Yeah, over.
That sounds very optimistic, and actually like Global Fund is also very like they are not homogeneous, and we could organize the meetings with the fund portfolio manager, with you, and maybe with UNODC regional office, who are now trying to develop the working plans in different countries on specific intervention for stimulants users, and they have they as Ala mentioned, this method recommendation. And I see from Anton Smazalevsky from WHO Europe that they could join the meeting. So we the position of Global Fund could also be influenced by technical agencies and by us as a regional organization. So it's not set on a stone position as from my point of view. And we are ready to step in this advocacy, because it's not only about Georgia, it's all about all the countries, and this non-flexible package of services. It's obviously the barrier for the responding needs of the people and for effective HIV prevention. So that could be one of the next steps after the meeting, and we could speak with all of you who are interested on the organizing this call with the Global Fund portfolio manager and with the PR. Actually, the key player here is PR in Georgia. NCDC, who, if NCDC is ready to start this dialogue, we will be happy to support it. If anyone want to step in the discussion, or we could close the meeting at the end. Georgi, or do you want to say something as a co-organizer?
No, I would like just briefly say one comment and then maybe summarize from our side. So I agree that this meeting would be like super appreciated and super useful, because the role of the technical agencies is of utmost importance to kind of support our national level discussions. Probably most of us saw the new UNH strategy, which specifically for Eastern Europe and Central Asia region recommends to specifically focus for the users of stimulants and psychoactive substances, which is extremely important at the moment. In general, I would like to thank everyone for the participation, specifically EHRA for the initiative to organize it. It was a very timely initiative, and it's always good that to have some point from outside, because in national discussion we are a bit sometimes limited, and it's good to also have the regional presence and regional support. So thank you.
Sorry, Gana, this is Ketevan.
Yes,
I'm very sorry. I had another meeting. I couldn't join you before. Thank you, everybody, for organizing this very important meeting. And regarding the PR plans and offered advocacy, of course, we highly appreciate it. And in addition to advocacy, Ghana, it would be very important to think about the intervention, actual interventions that could be included in the proposal, because basically we have a green light to include something regarding the stimulants and the non-injectable drugs in the proposal, but the question is about the activities that could be supported by the global fund. So please, everybody, think about this also.
Thank you very much for
Thank you.
for this promising comment, Ketevan, and thank you for being with us. And actually, with the interventions, I guess that we need to take into account what is in the pilot of MDM and what is already piloted by Mandala, and what is now in as intervention introduced in Kazakhstan and Moldova as a key good examples. So we have something to build upon.
Very good.
Thank you very much for this discussion. Sorry for keeping you so late, but it was fruitful, I guess. And thank you for coming to our meeting. And on behalf of all co-organizers, I'm very happy to have you here and to have this discussion. And I hope that it will continue in the changes in the package of harm reduction services in Georgia. Please keep safe and healthy. Be vaccinated if you have this opportunity. Hugs to everybody. I miss you.
Thank you. Thank
See
you.
around.
Thank you. Bye.
Thank you very much. Thank you. Goodbye.
Thanks. Bye.
Big deal.